and thank you for joining this conversation with me on how to promote inclusivity. My name is Marlene McNeese, and I have spent the past 3 decades serving the needs of communities in a variety of professional and personal spaces. I want to begin by sharing a little bit about myself as it relates to my experience with promoting inclusivity, and to provide a little bit of an overview of what I hope will be key takeaways for you to use in your own services and programs. My career began in Houston, Texas, where I worked for an organization serving youth and young adults. These adults and young adults were experiencing housing insecurity or a lack of permanent housing altogether. The team I worked with supported drop in centers, public assistance offices, and of course, street outreach, providing HIV testing, health education, and other support services as it related to housing referrals to trans and gender nonconforming individuals. As you all know, the demand remains great and the resources are few. Unfortunately, even still today, there are few housing opportunities for youth who need them that don't attempt to force fit them into spaces that aren't safe or responsive to what they need. I went on to work as a substance abuse counselor and program leader inside of the Texas Department of Criminal Justice, both in institutions and halfway houses, for justice involved individuals diagnosed with substance use disorders and also being vulnerable for or living with HIV. In the more recent past of my career, I've been working and managing public health programs, more specifically responding to the overlapping syndemics of HIV, STIs, sexually transmitted infections, and viral hepatitis. It is here where I had the very unique opportunity of experiencing one of the world's largest community based testing campaigns, bringing full clinical education, treatment, and laboratory capacity out into community in a variety of settings. We served in malls all over the city, in pharmacies, in clothing and technology stores, along with parking lots, just to name a few. A few key spoiler alerts I will share with you what made this intervention so successful that caused it to be replicated both in large and small jurisdictions across the country really centers around two key principles I'll share more about with you today, and that's access and partnership. And we'll get to those in a minute. Lastly, as an African American woman with more than 30 years of recovery from substance use and 5 years of survival from breast cancer, I offer my experience and expertise with being unfortunately excluded in intentional and unintentional ways from services that I desperately needed it when I needed them. So I'll get started. After watching this brief video, there are three objectives that it is my intention to leave you with the ability to do. One is to develop a deeper understanding of what is meant by inclusivity in community serving organizations. And two, describe three essential elements of inclusivity. There are more, but I believe that these three are specifically all encompassing. And then finally, to design ways in which you can integrate inclusivity into the daily operations of your programs and services. So let's get started. Have you ever felt excluded? Just wanted to pose a question to you. Of course, we all have. As an African American female, with all of the history I just shared with you, I certainly have lived at the intersectionality of gender, race, and co occurring conditions that have been countless times where I felt as though I've been excluded. And here is where I want to intentionally begin using a key word that I believe is missing from guiding many of our public health interventions and responses to HIV. And that word is intentionality. Intentional inclusivity. And let me explain. So let's start with beginning to define what inclusivity really means. Oxford's dictionary defines it as the practice or policy of providing equal access to opportunities and resources for people who might otherwise be excluded or marginalized. Cambridge goes on to describe a more simplistic approach as the fact of including all types of people, things, or ideas and treating them all fairly and equally. And I suppose these descriptions are fine. And as a noun, in inclusivity in its purest form, that certainly is adequately represented in those definitions. But I'd like to approach it from a verb, from an action based perspective. And for me, inclusivity is what we do every day in every way to respect and recognize those who we serve. Again, intentional inclusivity. There are many talks, I'm sure you have heard, around inclusivity that may focus on issues related to race and racism. Other talks have reminded us that inclusivity also relates to gender and sexual orientation, and that there's a need for diversity in programs and services to reflect, local community needs. So, yes, indeed, I think it also includes ensuring a diverse workforce is necessary to promote equitable and accessible health care for those underserved and vulnerable populations. All of these things have been emphasized in talks over and again for many years. But I believe much more work needs to be done to actually achieve inclusivity. To do this, I'd like to explore three essential elements of inclusivity specifically. The first, one that I hope, quite frankly, is already a part of your approach to health services and program, and that key element is equity. Ensuring equity. It really demands that we go further than just making sure everyone has the same. As health providers, we are required to recognize that health resources should be allocated depending on the needs of the people, and that these needs we recognize are complex and diverse. Equity is aligned with social justice. What we learned through COVID-19 and the environments that we were forced into for the last several years, there have been a tsunami of health research that has highlighted how communities traditionally impacted by inequitable health outcomes have been most impacted by COVID-19. These disparities continue to be realized over and again, regardless as to what disease state that we're talking about. The research continues to reinforce the impact of systemic racism, implicit bias. These have been maintained and sustained in health environments for decades. This entrenchment of bias and lack of inclusion that currently exists in our allied health programs as well as healthcare services have been maintained for decades, but they require new scrutiny. They require new critique and a new refocus. In order for vulnerable communities to really gain the knowledge, resources, and health literacy skills to better realize their own health outcomes, we have to assess and reimagine changes that could be made to ensure equity in the systems and programs and how we serve our people. In order to achieve inclusivity and health equity, we must address these historical and contemporary injustices. We do that by overcoming economic, social, and other obstacles to health and wellness and eliminate preventable health disparities. Just to be specific, we have preventable health disparities throughout our HIV work today. Acquiring a new HIV infection, as an example, is a preventable health disparity. The Mpox outbreak response in many places around the country unfortunately produced preventable health disparities. Access to pre and post-exposure prophylaxis for HIV in many communities remain preventable health disparities. Drug overdoses are the leading cause and rise of mortality rates among young people and middle-aged adults. More Americans now die of illicit drug overdoses than from car crashes and even gun violence. In April of 2021, the number of fatal drug overdoses in the United States over a 12-month period surpassed more than 100,000 for the first time. One of the primary drivers of this substance use epidemic is opioids. According to the 2020 National Survey of Drug Use and Health, more than 9.5 million Americans misused opioids in 2020. As a result, more than 70% of overdose deaths in 2019 involved opioids, including prescription opioids, heroin, and synthetic opioids such as fentanyl. And the number of annual opioid deaths in 2020 was 6 times the number in 1999. And dare I say today, we hear countless times that there is no absence of fentanyl in the illicit drug supply in the United States today. Every single supply of drug contains some amount of this very dangerous illicit drug. Yet all of these overdoses, all of these deaths are definitely preventable. Medication-assisted treatment, the use of medications in combination with counseling and behavioral therapies can successfully treat these disorders and help sustain recovery for some people struggling with addiction, thus helping to prevent and reduce these opioid overdoses. I believe, and why it matters in a talk around inclusivity, is I believe it is the bias and the stigma surrounding the perceptions of people who use illicit substances that excludes them from gaining full access to the services they need within health systems. Community health programs like yours should use these examples of preventable health conditions and disparities as a real call to action for changes that are necessary in our own organizations and throughout the current health system. One where inclusivity begins to become normalized, where systems are more responsive to the people that they are serving, and where systems begin to measure, monitor, and support health equity for all of the communities. Health equity, key essential element of inclusivity, number one. Number two, I think the second essential element of inclusivity surrounds access. You will all have to forgive me for getting on my soapbox for a minute here, but I am personally baffled by the principle of operational hours of service delivery still being Monday through Friday, 8 a.m. to 5 p.m. in brick and mortar spaces. It remains a challenge in our industry today, and I do not understand it. I recall a recent report that was published about the proliferation of the number of community health centers and agencies throughout the Houston-Harris County area in a variety of geographic locations over the past 10 years. But despite this proliferation of service sites and institutions, what was really more prevalent and astounding to me in the report, it really showed that access to health services, especially in these vulnerable communities, actually reduced during that same time frame. So certainly, I believe there are a number of factors that relate to the decrease, including the reduction in available staff, reductions in the labor force. But a key finding of that report that I believe received little intention or effort from these same community health centers to ensure that the days and hours of access to these services were truly responsive to the needs of community. My philosophy, quite frankly, is a well-rounded approach to improving access and inclusivity should be more than a cliche. We shouldn't simply just talk about it, we should actually be about it. And making sure that service options are available to our community is just simply a no-brainer. I think the service delivery options also, when I'm speaking of access, should be as diverse as our communities. No wrong door approach to testing, as an example, would be a complete toolbox of community and clinic-based testing options, as well as home test and home delivery options. Virtual care or telehealth has improved not only access in some rural communities, but also has improved health equity. Clinicians can pre-screen patients virtually, sending them in keeping them from going to a crowded facility, but also can help to partner with community organizations like you all to bring more specialized care closer to the individuals in the communities that are underserved by health services in otherwise spaces where they would have to travel oftentimes hours and hours in order to receive that same care. So I think strategies to promote inclusivity and access should also take a whole person and whole wellness approach. Inclusivity is not just responding to a singular disease state like HIV. The U.S. Centers for Disease Control and Prevention has taken a strategic approach around addressing syndemics. Syndemics being defined as epidemics of diseases or health conditions such as viral hepatitis, sexually transmitted infections, substance use, and other behavioral health issues that interact with each other and truly by that interaction increase the adverse effects on the health of these same individuals and communities. So the social factors of racism, homophobia, and poverty can also exacerbate the negative impact of linked epidemics. So collectively, addressing whole people and having syndemic approaches in our communities are just a cornerstone and should be a key element and principle in creating access and being able to provide inclusive services for the people that we are serving. Access to promote inclusivity also involves the acceptance of marginalized communities in these health delivery settings. I spoke a minute ago about the stigma and bias that keeps some members of our community away from darkening our door. But part of what we hope to do is to attract, and not only attract, but to retain. And in order to do that, we've got to create acceptance and inclusion. And it should be an artifact and an identifiable aspect of every part of our organization. This includes the signage to how individuals are greeted even before they open our door. The technology we use and social platforms, social media platforms that we use, along with services that are either provided through those platforms or supported by the organization to use those platforms for services. I just believe the use of new technology in many of our communities, that may be the only language that they care about and that they speak on the day-to-day. In many of our communities, that is the platform of trust. And so I just simply believe that we've got to be adept and nimble and be responsive. You can't be a Facebook girl in a TikTok world, you know. I believe these kinds of intentional approaches around acceptance can reduce individual risk of isolation and depression. When folks feel excluded, it may cause anxiety and worst case, self-harm. So increasing social support and connectedness, creating safe spaces where individuals can receive validation in their thoughts and feelings, not be judged. These activities and approaches can forge new and positive relationships and associations with health services. And we have to remember, you may be the first or only health provider that some of our community members may ever experience. And so finally, I believe the third essential element is opportunity. So opportunity for inclusivity begins, I think, with language. I recently heard that language is a social determinant of health. And when I heard it, it resonated with me on so many levels. I think one strategy to increase purposeful inclusion is using language that is consistent throughout your health organization and throughout your health services. As we expand our knowledge and aim for inclusivity and equity, we've got to ensure that we advocate for the people that we serve and include language that represents them. And we can't just talk about it, we really have to be about it. And I think a critical step in ensuring that we are using appropriate language and language that is responsive and creates relationships of trust in our community centers around including community members in the design of our materials, our services, and what matters of program importance there are to them. So again, this sentiment of intentional inclusivity and using opportunities to be able to do that. I'll pose a question to you. Where might we discover additional opportunities for inclusivity? As an example, how often do you build inclusive demographic data collection tools that allow for open-ended responses around individuals' own self-descriptors? I think opportunities for inclusivity exist all around us. I will certainly illustrate it in my last example using partnerships. In the community testing strategy that I described, we were able to test an average of 6,000 youth and young adults each year over a period of 30 days during the summer. And this feat obviously could not have been achieved by one organization, and in my case, by the public health department operating alone. In addition to our long-standing partners and community-serving organizations, we also leverage medical schools and students. We worked with academic partners. We worked with paid and unpaid volunteer members of the communities that we were reaching. These partnerships included clearly defined roles. They included expectations where everyone understood and everyone knew what value they brought to the table. Turf war and egos were laid aside by the common mission and by the public recognition of the value that each one of those sector partners provided and their unique expertise. You know, I'm always reminded that the National HIV/AIDS Strategy and the Ending the HIV Epidemic recognizes that no one industry alone will be able to achieve these goals. And we have to move forward with creating seamless new ways of service delivery that minimizes access points for the people that we're trying to serve and include, and really create and promote dialogue and collaboration across a diverse group of organizations. We all may have different perspectives, but it really could be the key to creating and identifying new ways to ensure communities are included and have access to those services that they most need. So my final objective today, I hope to leave you with ways in which you can design how to integrate inclusivity into the daily operation of your program and services. Promoting better inclusivity within your organization doesn't have to immediately involve major changes to staffing or expensive education programs. These are just simply a few steps that I think any organization leader or staff can make today that may not require any additional resources at all. So one, I would start by saying there's always opportunity to speak up about inclusion. When health program staff and leaders are well informed about what the issues are that are affecting inclusivity, staff become better equipped to create safe and progressive environments where gender binary norms are challenged and staff can learn to use correct pronouns, and even beyond that. When staff receive training on how to be an effective ally, I believe it can help to highlight program practices and policies that may be harmful or stigmatizing, and this behavior can be highlighted so that it can be avoided. So taking risks and speaking out allows for more opportunities to discuss, to respond, to intervene in any behavior, action, or language that promotes exclusivity and not what we hope to see through inclusivity. Second, I think we should think about how we communicate with each other and within programs and across programs about the work that we do. We should set up training programs for team members specifically geared to talk about how we communicate and what language we use. We should make sure that training courses and all of the work that we do to involve and increase diversity, that we don't just assume is a no-brainer that we think people should automatically know the right things to do and the right things to say. And this is where we have opportunities to call people in instead of calling people out, quite frankly. So it's not always a no-brainer. And I do think some of these values and activities and actions and new skills and abilities have to be learned. So there are plenty of diversity, equity, and inclusion training courses offered and technical assistance providers all over the country that are widely available today. Be sure to take advantage of them. And another note about training, I think training specifically on LGBTQ topics, it may go without saying, but I'd be remiss not to include it. I think are more particularly effective and impactful if they are co-designed and co-delivered by members of these various communities. And I can tell you one of the most impactful conversations I've witnessed included women of various ages and backgrounds who were living with HIV, and they had worked with the meeting conveners who wanted to do a new reach and training with a group of medical professionals. The center of the conversation was around missed opportunities to diagnose them earlier in their HIV disease. It was remarkable to hear their stories, to describe those missed opportunities where they felt excluded from services, from tests. But it was equally remarkable to watch the invisible light bulb sort of go off in the heads of these providers who learned more about how they could have been more intentional and how they can move forward through the adoption of routine HIV screening as one example for their patients, trying to put aside their biases about whether or not they believe their patients were at risk. So just it's important to have the voices of the people, and again, to have an inclusivity talk and not mention that, I just think I would be remiss. I think we also should respond from a place of personal experience. I speak often of my own truth, and I believe in the power of telling your own story wherever possible. I believe this helps to raise awareness and identify ways in which our services can be improved and be better and reach more people. And you never know what may resonate from your story with another. So be vocal and be responsive from your own personal place of experience. Treat people like people. I have seen countless of occasions where I'm still shocked by it and it still happens, and we're not perfect. None of us are perfect. But we've got to recognize truly that we all have unique goals. We have unique strengths, weaknesses, experiences, and no two people are exactly alike. And in that regard, and in my years of experience with managing and leading small and large teams, I cannot manage and motivate no two people in the same way. While working to even address community needs through our programs, our approaches and service delivery can't be done in all communities in the same way. During our community-based testing campaigns that I described, and certainly throughout our outbreak responses to infections over the years, I've learned one thing for certain is that you cannot design programs from one cookie cutter model. That evidence-based interventions must be adapted and modified to truly be responsive to the uniquenesses of these communities. And if you don't spend tons of time or resources or money on inclusivity training, please listen to this. This one simple rule, and really make it the focal point of all of your service delivery culture. And that is treating people like people instead of some collective based on a set of traits that we can't change. Also, make sure you pay people for their time and input as we work with communities and they help us to design, better programs and services. I know many of you probably have experienced the same thing professionally and personally yourselves. But people with lived experience are often not treated as valued subject matter experts and deserving of compensation for that expertise. And so my takeaway for you is to remember that simple principle. If you hear nothing else from this talk, treat people with respect, treat people like people. You will earn respect. It's really just that simple. Last two, challenging stereotypes. One way to promote more inclusivity is to look for places where things are too homogenous. I look around my workplace all the time. When I walk into other spaces, I look for the homogenous nature of the room and start asking questions about why that is. I remember being in a conference surrounded by, well-intentioned, well-meaning professionals, health professionals, who wondered about how to better deliver health services to their constituents of African American patients. But the entire room was filled with nothing but Caucasian individuals without one African American patient or community member or anyone in the room to help answer that question. So I do think it is up to us to begin challenging some of these areas and spaces that are not inclusive. And I think there are other simple ways that we can do that. Addressing and looking at what are our workplace dress code policies is one example that, we have tried to look at over the years and modify, quite frankly, over the years. I think dress code policies can become more inclusive and responsive to not only the staff who are working in the organization, but when we're out in community. And it matters that we look and feel representative of who it is that we are there to be working with. I also think you should look for ways to ask questions of your community constituents and community partners. Include as many diverse voices and types of people as even possible. I know it's time consuming. Sometimes it's uncomfortable and certainly not easy to do. But I think the more that we ensure that we ask others questions about how they feel about our efforts toward inclusivity, I just think the biggest mistake we can make is assuming that we know all that we should be doing around inclusivity instead of asking the people who we may be serving and what they would like us to do differently and what they would like to see differently. And after we ask the question, make sure that we listen and that we're humble about what we hear. And in that atmosphere, I think we create space to better make these changes. Finally, embed inclusivity in your organizational brand throughout the community. A great way to promote inclusivity within your organization is by promoting inclusivity outside of your organization. Be vocal, brag about your efforts through social media, through career pages, through your agency's website, or wherever it makes sense to do so. This kind of sets a precedent for everyone looking to join your team or everyone who may be served by your team. It also keeps your organization accountable publicly. However, when you do this, make sure you are actively practicing what you are preaching. Ensure that you are hiring with inclusivity in mind by promoting jobs in underserved communities. We go far beyond the traditional promotion of job opportunities through our, government public health website board. We intentionally try to make sure we are digging deep into community to make sure it is known for individuals who may be attracted to work and support some of these programs and services inside. So make sure you do that. Also, elicit and gather data and feedback on whether or not the people who are receiving your services, they feel safe, respected, and included in your organization. So if you're monitoring and you're measuring, hopefully, ideally, what gets measured gets movement. So in closing, I just really want to thank you for your time and just hearing this brief overview about how you can learn and adopt new practical ways to promote inclusivity in the work that you do. It should be promoted as a verb, as I said in the beginning, and become evident in everything that you do. Remember the three essential elements of inclusivity: equity, access, and opportunity. And lastly, take the time to specifically define ways to better integrate inclusivity into the daily operations of your programs and services. Whether this is done through formal modifications in your organization's policies and procedures or through informal conversations with members in the community about their needs. But find ways to create opportunities to ensure inclusivity and promote to others on how you are working to achieve it. So thank you so much again for watching this video. I am Marlene McNeese. I live in Houston, Texas, and I look forward to continuing our work to serve and partner with communities together.